We'll move on with our second speaker, who really doesn't need much introduction from me, but I think I have to. He's Professor of Gynecology at Imperial College. He's a consultant at Queen Charlotte and visiting professor at KU Leuven, and of course, past president of ISWOG. Professor Bourne's going to be talking, he's got two talks this morning, but the first is about avoiding error and diagnosing miscarriage and predicting probable miscarriage.
Well, I don't know how far we'll get through all that lot. I seem to have, I've got a little tail here. This is quite interesting. Hang on, let me just sort myself out. Right, well, morning again, and I'll see how long my voice lasts. For some people, that would be a blessing, I imagine, so we'll give it a go anyway. So this is a talk which, some people would say, well, you've heard before, but I do think it's important to highlight, because obviously one doesn't know how experienced they are. I mean, a lot of you no doubt are super experienced, but I think also, for people who have not done a lot of pregnancy scanning, it's just really important to emphasise how in early pregnancy, really, in probably most cases, you don't do a lot of harm by watching and waiting. Of recent years, obviously, even with ectopic pregnancy, I mean, we watch and wait and repeat HCGs and then make a determination whether we have expectant management or use methotrexate, for example. Whereas I remember, ectopics were always an emergency, when I was early on as a trainee, certainly. So even in that situation, just a little bit of careful expectant management is rarely a bad thing. So I think the rush to do stuff should be avoided. And of course, if you make a mistake in early pregnancy, it's catastrophic because potential is there to terminate a very much wanted pregnancy. And sometimes people talk about it's almost like a hierarchy that everyone, if there's a stillbirth, understandably, it is a total tragedy. But equally, if someone loses their pregnancy at 7, 8, 9 weeks, once they have a positive pregnancy test, their life changes effectively. So there isn't really room for error, although of course we're all human. And of course, certainly in the UK, we have a fairly lively media, but you really don't want to put yourself in this situation because every year we get headlines like this in the newspapers. I mean, you can just go online and sort of say, miscarriage, misdiagnosis, and put the date, and you'll get a headline. Quite understandably, because people completely cannot understand how this could possibly happen, and it's not that unusual. People go and have a scan somewhere, and then they want to have another scan, or they perhaps have a scan in the private sector, or one of these sort of come and have a scan of your baby shops, which we see around the place, and then they come in for surgery, for example, on the unit, and you see they've actually got a viable pregnancy. And I don't like doing medical legal work, but I do get sent the odd thing, even if I don't do it. And there's a lot of cases come through of people being told their baby has died when it hasn't. So it sounds like this might be an unnecessary talk, but even if I just say this, I just want to emphasise that it really does matter, and you do have to take care, and guidelines are there for a reason, basically. So anyone want to hazard a guess, just as an example, I'll ask Chris Kyriakou at the front. How do you feel about this diagnosis on the basis of a first scan? Anything you'd like to highlight? Perhaps not ideal.
Gestational sac is less than 25.
Well, yeah, I mean, there's a lot.
And it was a TA.
TA.
Yeah, so this was a private scan in London. Well, exactly. It's a transabdominal scan. Fantastic. Which is not, fair enough. And if you see the heartbeat, people will do that. I tend to scan vaginally straight off, but there's nothing wrong with that. But at the end of the day, they find there's a small sac. They can't visualize the embryo. And they then decide that the gestation sac is 15 millimeters, which I doubt is a mean sac diameter anyway. And they've said that this is confirms a miscarriage. I mean, this is disaster from start to finish, basically. And then she paid, I think she paid £280 for this joyous report. I mean, it happens. Really, I just think it's important that people follow guidelines. And, sure, people can do an abdominal scan. Patients often say, I don't want a vaginal scan. Fair enough. But if you can't see what you need to see, then you have to do a vaginal scan. Personally, I do a vaginal scan, but, we do have, I understand that's not always possible. So be careful. And you often get forced into making a decision. I've always liked this paper because it's Cecilia Bottomley's paper from years ago now, but it just shows how even when you look at 5 weeks, the chance of you having a definitive scan result is only about sort of 15 to 20% or so. And even at 6 weeks, it's 40 or 50%. So it's quite likely you're going to have a pregnancy where you're going to have to make a decision. It's a pregnancy of uncertain viability, or it's a PUL, and you have to decide what to do, bring it back for a scan or bring it back for blood tests or whatever. But you're making a decision, and you've got to be careful that you don't make the wrong decision and say, well, actually, no, I think this pregnancy is not viable or whatever, or give methotrexate for the wrong reasons and so on. And I'm going to hear from Chris about that probably shortly, but, despite the fact it would seem self-evident to everyone who is sitting here and does a lot of work in early pregnancy, it's amazing, it happens a lot. I mean, there are industries of lawyers in America who basically earn a lot of money for people given methotrexate for supposed ectopic pregnancies when they turn out to be intrauterine pregnancies, and of course you have methotrexate embryopathy, which is seriously bad news. Happens here too, but not to the same extent, but in the States it's quite a big deal. So, stick to guidelines. Yazan Abdullah did the original paper defining the cut-off values for miscarriage. You may sometimes say, well, this is a bit of a pain. Why do we have to stick to those? It's obvious it's a miscarriage, etc., etc. But this is Jessica Preisler, and she followed this up with a paper in, what was it now, 2015? So this is about 2,500 patients, and I don't know if you can see very well here, because it's not the biggest of screens. But if you look back at what it was in America, just to give you an illustration of how messed up this was, the mean sac diameter at 16, you have a specificity of 96.7, it's a false positive rate of about 3 to 4%, and confidence intervals of 94. So in other words, that's up to about 5% false positive rate. It's 1 in 5, basically saying that the mean sac diameter is that. I mean, that's a disaster. Even in the UK, it was about 1%-ish. So that's about 1 in 100. Still unacceptable, really. Again, with confidence intervals, sorry about my voice, that can mean it's about 1 in 50. That's why it was put down to 25, because that gives a margin of error. Plus, there is inter-observer variation. If two people, you don't all measure the same. With 2 experienced people, we showed they could vary the size of the sac by quite a lot, especially when you consider it's meant to be 3 diameters. You can see how there's variation. So these cut-off levels are there for a reason, and they matter. And if you go over here with CRL, look at this, 5 millimeters to define a miscarriage in America previously. Again, false positive rate ranging from 91 to 99, but that's quite a big confidence interval. So it could be as much as 1 in 10 almost, or wrong. And of course, it ended up being at 7 millimeters. So it's not, you can't fudge it. You have to stick to the rules, is what I'm trying to say. And the rules are there for good reasons. They're based on reasonably decent data and with reasonable confidence intervals. 7 millimeters, it's even not ideal, but still about 97 to 100, 25, 99 to 100. We'd only get better with thousands and thousands. I mean, that's as good as we're going to get. So it's reasonably good, but an awful lot better than it was, where it was just wrong. That's why doing good diagnostic multi-centre studies matters, because this is a multi-centre study. You've always got to see, well, it's all very well us saying that this is the cut-off, at Imperial. Does it work in your hospital and lots of other hospitals? This is this is why Dirk's, the IOTA study really matters about ovarian matters. You have to do big multi-centre studies. So this matters. And the summary of the BMJ paper, on the first scan, supported and validated what we'd said back in 2012 with Yazan. It also said, we looked at repeat scans, and it basically also showed that if you have an embryo with no heart activity, and it's not there and there's no heartbeat a week later, then it's definitely a miscarriage. But one thing which I think is important to point out was it showed that if the mean sac diameter is less than 12, you should repeat the scan at 14 days. Not 7 days, not 10 days, but at 14 days. Basically, if you want to make sure that you have good specificity. It makes sense, actually, when you think about it, that the size of the sac kind of makes a difference, doesn't it, at the start? If you want to say that the sac is over 12 millimeters, you can see them in 7 days. I think it's simpler just to see them all as a couple of weeks. This makes it easy. You don't have to start thinking too hard about it. But just bear that in mind, because the college, if you look at the guidance, says see them in 7 days. That's not evidence-based and is incorrect. So, One other point. Guidelines are fine. I can tell you about cut-off values, but none of us are perfect. If you're telling someone that their baby has died, it's not a bad thing to get a second opinion, not only for yourself, but think about it if you are a patient. How much more sort of, well, it's kind of, at least you think someone else has checked it. Because if you go home and you think, Christ, did they get it right? You know, there is some reassurance at least that someone else has looked at it. I don't think it's a bad thing. You say, I'm just going to call in a consultant, they're going to check the heartbeat and everything, and you actually have a look and do it. I think that's actually important, both from our point of view that we don't make a mistake, as we all can, and secondly, from the patient's point of view, I think that is an important thing to do. And training and quality control obviously matters as well. So it's not just about cut-offs, it's about how well people are being trained properly and about, not being so, not having a problem just saying that this is the policy of the unit. We always have miscarriage checked by a second person. Good for us, good for the person who sadly is being given that news, I think. I wanted to say something about IVF pregnancies. I think a lot of people sometimes think, wow, look, I know the time of embryo transfer, and I can see there's no heartbeat, and I can see this is the size of this. This is ridiculous. It's going to be a miscarriage. And why am I doing this? This is Sugar Muriezu's work on a PhD, 10,000 IVF embryo transfers. And it's quite interesting to see why that is not necessarily true. Here we have at 7 weeks. Now, you wouldn't expect that these are viable pregnancies, not ones that miscarried. And these are pregnancies followed up to the time of the nuchal scan. At 49 weeks, viable pregnancies, 4 to 13 millimetres. That's weird, isn't it? You'd expect them all to be the same, but they're not. So I don't understand why this happens. And these are for the same embryo, taking into account the stage of the embryo and all the rest of it. So you might say, well, this is obviously a miscarriage. It's 4 millimetres. I don't have to stick to the 7 millimetre rule because I know exactly when this embryo was put in. It's far too small. There's no heartbeat, so it must be a miscarriage. No, stick to the rules with IVF as well. Okay. So I think this is quite interesting, and we need to think about this. And of course, the other thing is what happens to these. We don't know. I'd love to know what happens later on. We know that they're viable at 11 to 14 weeks, but does having a small embryo, for example, mean there's a problem with preeclampsia? I don't know. What is this telling us? Not sure at the moment. Another point I want to make, particularly people online who may be in places where you have to use handheld machines, because one of the things that I think often comes up is all these things about miscarriages, about transvaginal ultrasound, but of course if you're working in an environment where you haven't got that, or culturally that's not acceptable, or you just have a handheld machine, does it matter? Can you use the same rules? This is Alex Novak's, relatively small numbers, but I think quite important. Just ignore this. This is just to make it look like we've done it properly. But the message is, with handheld machines, you tend to measure things a little bit bigger, both in terms of the mean sac diameter and the embryo size. Now, we haven't got enough numbers to make definitive comments on what cut-off values, but we do know enough, I think, from this to say you've got to be very careful. And certainly, I don't think we should be applying the cut-offs for vaginal scanning when we're using handheld machines. Now, that may seem entirely self-evident, but I think it's important to demonstrate this, and then I think we need to define what we should be doing. But just note, it's about 2 to 3 millimetres bigger, right, larger on vaginal scanning, which means you're measuring it smaller with POCUS, which means you could easily make a mistake. So if you're using handheld machines somewhere out there, for those of you who are online, take that into account. And also, you need to at least repeat scans probably at a longer time period, over at least a couple of weeks, which I think is a good idea anyway. But I just thought it was important to point this out. We've been talking about just telling people about their pregnancy. We've already heard from Harsha, telling people what to expect is, in my view, important. Because it's not helpful if you see someone and you know the pregnancy isn't looking great to say, come back in a week or whatever, or come back in 2 weeks if it's a mean sac, but if it's an empty sac, and they go away thinking, great, there's no problem. I think you have to manage expectations, because psychological disturbance to some extent is the gap between expectations and reality, and I think you need to close that gap so people are given realistic expectations of why they're coming back and what the likelihood is of miscarriage happening. I think that's a useful thing to do. Now, there is a paper on this which actually didn't show an improvement in some of the markers of well-being. I'm not sure that's the last word on this, and I'm not sure we measured necessarily the right thing. I just think it makes a lot of sense. There are things which are suspicious but not diagnostic of pregnancy failure, and you can see them listed here. This is a New England Journal paper, which was a consensus paper. And these are things we all know. and we know about the empty amnion sign. If you see a big yolk sac, these sorts of things are not great when we see them, but they're not diagnostic. But they can help you guide the patient and say, look, I'm sorry, we need to bring you back, but I'm not optimistic. We're not sure how this is going to work out. I think that's an important thing to do, but it's not diagnostic. There are prediction models, which have been done mainly by Cecilia Bottomley. This one is one which actually I think has pretty good test performance, and it's got big numbers with an AUC of 0.924, which basically means diagnostically or from an addiction point of view, it has good test performance. And this is now, can be used as a model, which you can, this is with Guinea, which I have to say I've disclosed I'm involved with Guinea, which is a company, but just to say that you can sort of put in the bleeding, presence of a heartbeat, sac size, and then it will give you a risk. And you can advise the patient the likelihood of the pregnancy miscarrying or being viable. So this is a viability model. So I think it's useful either to look at these soft markers, or you can use a sort of more data-based approach to this, but you need to tell patients what the expectation is. Okay, other things, we've mentioned this. I mean, this doesn't look right, does it? Okay, you see this straight away and you think, oh dear. So even as a heartbeat here, it's basically a vacuum-packed embryo, effectively. So you see these sorts of things, these sort of ratio, not a great sign. These are all things where you might say, it's not looking good. What about hematomas? This is an unbelievably good paper by someone called Maya Al-Mamar. Oh, she's here. There we are. So this is Maya's paper. This is the EPOS study. Poor Maya, a while ago now, but when she did a PhD, scanned 1,000 plus women, about 6 times each. This is about 6,000 scans. She's never spoken. It's the first time she's spoken to me since she's finished her PhD. Anyway, essentially the bottom line is there was no association found with miscarriage and hematomas, which was independent of bleeding. So it's basically, it says you've got a hematoma, that means you're bleeding. That's the end of it. Okay. However, hematoma does increase overall antenatal complications, which I haven't got time to go into now, but it is important, especially these, some of these big ones. I think you have to be aware things about prematurity and so on. And it's a debate: do they go to the prem clinic, or what do you do with them? But there's no doubt they have later complications, which perhaps isn't surprising. If they survive this, that this is not going to leave the pregnancy untouched. So I think people often measure hematomas and tell the patient gets incredibly worried about it, and they want to come back and measure it and all the rest of it. It's just a sign that they're bleeding, and I think that's what you tell them. However, it does mean that you need to have a strategy, and should have a strategy. What are you going to do with them long term? How are you going to manage this? Which ones? At the moment, I'm not sure. I think you showed about size and so on. I can't remember. The size doesn't matter, does it? And we probably need to work out. There probably will be some that matter more than others, but I think we need to do a bit of work. Anyway, Mayor can answer that question at the end of the talk. So shut up. No, I'm dying to say something, aren't you? What else shouldn't we miss when we're diagnosing miscarriage? We've seen a few of these. What are we looking at here? Chorionic bumps. We've seen some where people have measured, there we are, they measured this and said it was a miscarriage. It's a chorionic bump, same here. This lady came in with a miscarriage. This had been measured. In fact, there's an embryo. I know, again, people say, well, how can you do that? But it happens. Just be aware of chorionic bumps and be careful. You can kind of see how it happens, especially when the embryo is kind of behind or you don't quite see it. And you think, oh, it's just a sort of, hydropic-looking embryo or something. They're not that common, but they're common enough. I think about 1 in every 1,000 or so or more. So you're not going to see them a lot, but enough. And only one mistake matters. They are associated with, 1 in 1,000, well, more than that actually, sorry, 1.5 or whatever. You are more likely to be associated with miscarriage, but actually, arguably the majority maybe not go to a live birth. So again, these are not a sign that the pregnancy is going to fail. It is a risk factor for miscarriage, but it's certainly not okay to make a misdiagnosis. So just be aware of those. Just another error people make. What do you think this is? Anyone? What do we call this? Oh, fantastic. You've been spending time in Belgium, haven't you? Yes. So people see this aspect. Someone's had a miscarriage and they come in and they turn on the colour Doppler and the thing lights up. And you still see people going, oh, they've got an AVM. But in fact, we know this is almost always associated with retained pregnancy tissue, even if it's not immediately obvious there, and they resolve. And certainly if you take away the tissue or just let it manage it expectantly, the vascularity will regress. These are very unusual that they are actually true AVMs, in fact. Okay, so I mean, this isn't a critical miscarriage diagnosis, but I think it matters because people often, start doing all sorts of things and embolizing them and all sorts, when in fact the best thing is just do nothing, basically. How am I doing for time? Am I over? Just on.
Fine, you've got another 10 minutes.
I've got 10 minutes.
But with questions, so.
Oh, shut up. Sorry, shut up. Yes?
Tom, you need to stick with the lecture, I'm afraid, because your headset mic's failed.
Sorry.
Okay. Right. Right. So, moving on. Just a bit about ectopic pregnancy. First thing, statement of the obvious. This is George Condis. If you're online, George, hello, in Sydney. Emma Kirk's data. You diagnose ectopic pregnancy on ultrasound. It's not a presumptive diagnosis based on not seeing something. It's not a presumptive diagnosis based on certain HCG levels necessarily. We're going to hear a lot about this from Chris. And you can see here that George showed that prior to treatment, you should visualize about 90% of ectopics and see them. That's after follow-up. Emma Kirk showed that on the first scan, you should see them about 75% of the time. And that kind of fits with clinical reality with a PUL rate of whatever. But it's an ultrasound diagnosis. I just want to say about timing if you're looking at ectopics. People often say, well, don't scan people if they come to an early pregnancy unit. There's a cut-off value. We're not going to scan anyone until 7 weeks because that makes sense. But actually, it's interesting when you look at these data. This is again from Cecilia. You can see that if you're symptomatic, you certainly can't do that because you will see ectopic pregnancies in that group. It's not a good idea. If you're asymptomatic and you have people saying, I just want to have a checkup or whatever, it would seem not an unreasonable strategy to try and limit things. If people want a reassurance scan, what's the best time to come? I would say 7 weeks is perfectly okay, but if they've got spotting or bleeding or pain or whatever, you scan them, irrespective of gestation, apart from the fact they don't always know their gestation. But that's what this data shows. So running an early pregnancy service and limiting access based on gestation for symptomatic women is not a good move. So I'm just going to touch on where people, if you like, make mistakes. And we see this. There's problems with competency and training. Look at all this lot. Anyone think you're going to miss any of these? All of these have been classified as PUL, and I've seen come into clinics. But I mean, there's a problem there. I mean, if you can't see that, there's a training issue, right? I mean, so, people often let people loose in early pregnancy as a sort of place where you can let SHOs or juniors scan with very little supervision. And perhaps it's no big surprise when you actually sort of see these things. These are pretty big. Scar pregnancy, fair enough. But the other ones, I guess this one, these blobs can be difficult sometimes and, do take a little bit of expertise to be able to spot them. Okay? So the morphology of ectopic pregnancies, most of them, some of them, a bit, you're going to see bagels. The classic, when Ilan Timor and Steve Goldstein, this one. But we know that actually most ectopics, in fact, look like this. So they can be missed, or people can think they've seen an ectopic when it was bowel, and that's when you start situations where people start giving methotrexate and they end up with disasters. So, being able to actually scan properly actually really matters. And so proper supervision, as I've said earlier, matters. And with these, certainly if someone says there's an ectopic and it's something like this, then the scan must be checked by a senior person before anybody contemplates methotrexate. But these are probably not going to be rupturing, not saying never, probably. And so looking at the HCG over time, repeating it 48 hours and then making a decision and so on with senior input matters. Intracavity fluid, the Royal College of Obstetricians and Gynecologists says that this is a sign of ectopic pregnancy. This is Chris Kyriakou slide, which I've stolen off him, and here we are. NICE says that, which is actually the college's guidance now. But it's not. In fact, the chances are extremely low. This is Peter Dubilay's data, which actually I don't believe. Margot's data from our unit says it's about 79% or 75% likely to be associated with an intrauterine pregnancy, which I think is fair. In other words, it's a pointless test. It's not a sign of ectopic pregnancy, so forget it. So the pseudopsych should not be used, but I just think, again, still, it's out there. It's not an appropriate thing to be using. So, PULs, I think because of time, I was going to say something about PULs, but I'll leave it all to Chris, because that'll suit him. So I'm going to gloss over PULs and just get single measurements he's going to talk about. Not a good move. There is a good model that works very well he will talk about. I just want to say, finally, 3D and interstitial pregnancies, just be careful. There's another thing where mistakes can be made. If you look, again, at the Green Top guideline, which is in the UK at least is the guideline, it talks about using, I think it talks about three-dimensional ultrasound, and you can see the quality of the evidence is D, but it's encouraging people to use 3D ultrasound. Now, I think you've got to be quite careful because obviously we now have, I never know the dimension, it changed with ESHRA, but let's say pregnancy in the angle here, perfectly normal pregnancy implantation. But again, we've certainly seen people being told they've got interstitial pregnancies, and there's no doubt they can be tricky, but there's one, there is an interstitial pregnancy there on the right-hand side, but it's still not completely separate. You can't see loads of myometrium separating it from the endometrial cavity. So I think 3D, you need to be a bit careful about what you're doing. And again, if you suspect an interstitial pregnancy, certainly make sure it's checked by someone who knows what they're doing, because the risks there are significant. They're high risk if you miss them, but they're also high risk to get it wrong. In this situation, you could see this doesn't look right on the 2D. You think, what's going on? That's not right. But in fact, it's in the right place, and it will just develop into the cavity normally. So be careful. I mean, you can see that it's difficult if the pregnancy is there sometimes to differentiate between that and interstitial. Sometimes, is it low-lying or is it cervical? Again, sometimes you have to allow time, a little bit of time to pass. Scar pregnancies, same problem. Over the scar, what's going to happen? What do we do with them? Into the scar, you can make mistakes. It's not helped by the fact that up to relatively recently, the diagnostic criteria were, to say the least, loose. I mean, it used to be that it was any of those pretty well being present was a scar pregnancy, according to what the only diagnostic criteria around. It's improved a bit, but clearly this is not acceptable. I mean, any of the list. The following is a list of diagnostic criteria. This is ridiculous for diagnosing something. So more recently, I'll just turn your attention to the work being done in Amsterdam, which is Judith Hearn's group, and now this is a sensible sort of criteria to make a diagnosis of scar pregnancy, which I draw your attention to. So be careful. If you think there's a scar pregnancy and you have limited experience, send it to a referral centre, get someone to look at it who knows what they're doing, both in terms of diagnosis and treatment. I'm going to finish now because my co-chair is giving me a very dirty look. But just remember that sentence, okay? A lot of time I've seen in my time in ultrasound, everyone is, pouring so much attention into later pregnancies when things go wrong. But, it's just as important when things happen in early pregnancy as well. So training, taking care, following protocols are really, really important. I'll leave you with that. I'm so sorry about that, because I wanted to talk so much about hematomas and that wonderful paper.
Thank you.
Okay.
Thank you. That was great. We have no online questions, but please do post them if you do. But any questions from here in person? It's very boring.
Oh, sorry, my talk was so boring. Okay.
No,
right.
I've got many, but it's still so shocking, despite all those years, and probably more so for you because you're
Very old.
one of the
Yeah.
leaders in kind of trying to apply some standardization to the diagnosis of miscarriage, that 10 years on, or over 10 years on from Yazan Abdullah's work, that we're still in this situation where mistakes are made. And I think the first question is, why do we think that is? But also, I think one of the most compelling, people are always, it's just too conservative. It's just, why are we making women wait? And I think one of the most compelling data that was published around that time was Anne Pexter's paper with the inter-observed variability. I think people forget about that. And I don't know if you wanted to kind of comment on that.
I'm just seeing I have that data maybe. I'll just see. Maybe not. who knows, all sorts of slides here. Anything could come up.
Yeah. But
No,
people
I don't.
do, don't they? They say that. They say,
Yeah,
oh,
I mean, I think the point is, yeah, I mean, first of all, if you measure something at 7, it could be 6.2 or something. And we know that there's significant inter-observer variation, and particularly when you're measuring mean sac diameters. We even have machines which, if you measure 2 diameters, will say MSD, and making sure you turn the probe. So you really, the 25 was giving a margin of error, because you might look at the data and say, well, why not pick 20? Well, because 20 could be 16, 25 could be 21. Mm-hmm. So it's conservative for a reason, and kind of designed that way. And certainly in terms of bringing people back, again, actually we don't really have enough data to base those decisions. And certainly I think being conservative, is the only way to go. I mean, if it's axiomatic. There's one thing I always say someone would expect when they come to see a doctor they get right, is whether their baby is dead or alive. Really fundamental issue. And so, it's incumbent on us to explain why we bring people back. Understandably, it's upsetting for people, and I get that. And I also understand that, we bring people back and maybe for very low risk of getting it wrong, but that low risk is critical. And it's up to us to communicate properly with the women, or the people who are sitting there, why we're doing that. And in most cases, if we do that properly, they will accept that because they understand exactly why. And also, when you think about it, for an awful lot of people, we are encouraged to give people a trial of expectant management. So if you've got the diagnosis wrong, you're basically giving them a trial of expectant management of miscarriage in any event. So that again comes down to counselling people appropriately and warning them that the risk of miscarriage is there and that they might bleed and things might happen. And that comes down to looking at these markers of risk, which I was talking about. So it's not just psychological, it's preparing people that things could happen, Going back to your first point about frustration with why things don't change, well, I think, I mean, certainly if you look in the UK, there's no proper standardisation, there's no what I would call proper sign-off, if you like, for competency, which I will recognise, if you look at early pregnancy units, both as centres and units in terms of standards and how they're run, and audited performance, and also there's no, I find it really bizarre that, for example, we're not doing something with APU, maybe ISWOG, saying this is the sort of course you have to do in order to scan early pregnancy units and so on. And I think, again, it goes down to almost saying that scanning early pregnancy is easy, and there's a perception that anyone can do it, that you don't need to be trained, and it's kind of an easy place to be. If you look at, for example, the sign-off, and I mean, Harsha can talk about this because you're doing fetal medicine now, and how much fetal medicine stuff and sign-off you need, it's a totally different world. Mm-hmm. And this is what has to happen in early pregnancy. I don't want to make it like impossible for people, but I think there has to be a bar, and there has to be a recognition of early pregnancy and acute gynecology as an area which is a risk area, which is properly recognised and where training is appropriate. I think once it has that respect, it's not necessarily just that, it then means that you start having to demand certain standards, which at the moment just doesn't exist really.
Yeah, no, that's absolutely fair. Thank you so much.
Okay.